Edwards came from North Wales, and as our tradition is, we will first also introduce ourselves so she gets a better idea who came to enjoy this special session today. So I will start with myself. My name is Valerak. I'm Associate Director of THETA, and I'm also Assistant Professor at CHEME and Scientist at TGRI.
Hi, I'm Rhiannon Tudor, and I should explain that Nonnie's here. You may see, I have an assistant's dog, so I have very little sight. So I have an assistant's daughter today, because the dog is at home looking after my husband.
Please.
Hi, I'm Lauren. I'm doing my master's in health informatics right now, and I'm doing my internship at the Center for Global E-Health Innovation. That's correct. Hi, I'm Maya. I'm also at the Center for Global E-Health Innovation. I'm doing my master's in management of innovation.
Right, that sounds so cool.
I'm Eva. I'm research associate here at THETA and master student at Biostatistics Dalalana.
I'm the Alexander. I'm scientist and director for health economics and modeling at THETA and assistant professor at University of Toronto.
Thank you.
Hi, I'm Manuel. I'm a health economist at Health Quality Ontario.
Great.
Hi, I'm Lauren. I'm a research associate at THETA. I'm a professor here at Toronto.
I'm Aisha. I'm a PhD student here at THETA.
I'm Alex. I'm a health economist at THETA.
You sound like a brick.
You knew it's important.
Excellent. Brexit did that, did it?
Exactly.
There'll be more to follow. Okay.
I'm Ella. I'm a PhD biostatistician, and I hope to start working here in a few weeks.
Right. Yeah.
Hi, Susie.
I'm English. I'm a research fellow at TGRI.
Perfect.
I'm Alexandra. I'm a research analyst at THETA.
Joseph Emo, research associate at THETA.
Well, this is so cool for August, and you're all here. That's wonderful. I don't even know the two of us.
Stephen Gargoni, I'm a research associate at THETA. I'm Andrew, I'm a PhD student at THETA.
Jason, I'm a PhD student from the pharmaceutical branch.
Oh, cool.
I'm Elizabeth. I'm a research associate in cardiology.
Right.
I'm Sonia, research associate at THETA.
I'm George. I'm a biostatistician at UHN and an associate professor at University of Toronto.
What a second, you forgot your name. I can hear them whispering about my password behind me. Do you want me to put it in?
I'm Cheng O. I'm a PhD student at THETA.
Right.
Troy Francis, research associate at THETA.
Joanna, you met?
I'm Joanna Bilecki. I'm a research librarian here at THETA and also a moderator for the online participants. We have 4 people online.
Good.
Hi, Wilson Ryan, IT architect. We met earlier.
We did. I'm not forgiving you yet for messing my computer. Do you want me to put my password in? Is that what we need?
It's just waiting.
Yeah, so
okay.
we're just waiting.
I can talk anyway, you know, but we'll hopefully get some slides up soon for you. Yeah,
No.
So should I give them a little bit of background?
Sure,
What I've done? Because I just had my 50th birthday, but I consider I had a really exciting career already in health economics. And I think it's worth sharing for you guys who are starting on your pathway down the technology side or the health economics assessment side. So I did a degree in economics at the University of Aberystwyth, which is in Wales, and I finished my finals and somebody said, would you like to go and spend a year or 2 in Canada? And I went, yes, and I just finished my finals and I don't know what I'm thinking about. And I had an interview and I had a teaching scholarship to Calgary. And I did my master's. I'm a graduate at the University of Calgary, so I'm really happy about that, to come back to Canada. And since then, actually, I also had a Commonwealth Fund Harkness Fellowship. Has anyone heard of Harkness Fellowship? They run through New York and they're fantastic. And I know Canadians are eligible for them. It allows you and your family to go and live in the States for a while. Maybe not at the moment, but yeah. And study. And I went to group health in Seattle. So just to go back, my master's. I did my master's degree, and then I went to York and I wanted to study health economics. Who's heard of Alan Williams here? Well, here he was the professor who invented the quality adjusted life year, our side of the pond. I know that there was Enthoven and other people this side who worked on healthy year equivalents and things like that, but really the idea of the quality is, you all know what a quality adjusted last year is. Yes, I'm not going there. So the idea being that I was very privileged to go to York at a time. I was one of the first PhDs in health economics in the UK, and then I worked with Liverpool Health Authority. So I've always had a public health contract as well as working as an academic, and I think that's really nice because you end up quite grounded because you've got one foot in the real world and one foot up the ivory tower. Okay, right, let's see if this is going to work, and if it isn't, my daughter's going to help. She gets extra pocket money. Okay. So, who remembers the film recently, Eddie the Eagle? Have you seen the film? It's a great film about this crazy Brit who decided he was going to go and do ski jumping. And that's me learning to ski near Banff. So I thought, well, it's nice to put up a photograph of my very fun time I had learning economics, econometrics. I wasn't very good at all that, but I had a go. And then I got interested in health economics. Oh, it's not reading, no, I'm just reading the top. That's BBC News. Yeah, so who has heard of Professor Sir Michael Marmot? The Marmot report, which was on the Whitehall study, and the Whitehall study was looking at the gradient of if you like, health and well-being and employment. And it showed actually that the more control you have in your life, well, probably in your life generally, but in terms of your work life, the better your health and reported quality of life. Okay, so he's been a really influential epidemiologist. And if any of you listen to BBC Radio 4 on radio, there's a program called Desert Island Discs. And this is in the UK, a real institution where somebody famous comes and chooses 8 records. And then they get to choose a luxury. And there's this hypothetical island where they're going to be staying. Now, and if you want an epidemiology lecture, listen to his Desert Island Discs, because he talks about his records, but he also talks about epidemiology. And he talks about medicine being failed prevention. That's kind of tough on the doctors. But I think it's really interesting. And the other thing he said was, if economists ever put forward policies that hurt children, they need to re-examine their toolbox. So what he was saying was, we can do our ISA calculations, we can do all this stuff, but we need a kind of logic recommendation. So just recently, there was a study. We've been in severe recession for the last 10 years in the UK. We're having a tough time in the UK. There are all sorts of horrible things been going on. You know, we've had terrorist attacks, we've had fires in Talbot building. Honestly, it's not much fun at the moment, so I've come here for a holiday and to talk to you. So there's evidence that the increase in life expectancy has slowed. And his proposition is, which is challenged by the Department of Health. I love the fact that they kind of go, no, actually, we're doing everything fine. I love that. They're actually arguing, he's arguing that it's due to recession, to austerity. So this is a real-term reductions in spending on health, on the NHS, our National Health Service, tax-based funded system, free at the point of access, apart from some charges for drugs, teas and glasses. So the rest of it all free at the point of access. And we use waiting lists as a non-price rationing mechanism. So this is all slowing down. And, you know, the question is, well, how do we start thinking upstream a bit?
The health economist.
Okay, I like this. This is Einstein and a sign in his office. I love this. This is about what we try and measure. Not everything that we can count, and not everything we can count. Oh, I get it wrong. Anyway. I know what it means. But it's important because it's kind of like, we've got to think about what we're measuring. So the job of the health economist is to identify, measure, and value. Okay, we know that. And you guys who are involved in technology, and linking up big data, that's changing. Because I grew up in the day where we get patients to fill in service use questionnaires. You know, how many times have you been to the doctor? How many times have you been to the dentist? All the rest of it. And now it's possible to link up data sets, but often that doesn't work either, like my technology today. So those of you online today, apologise for the prompt. Okay, this is an interesting slide. It took me a long time to find this slide. So just to give you a guide of where I'm going today, I'm starting out my history as a health economic, then my interest going upstream, thinking about public health economics, and then thinking more about the circularity of public health. Okay, so this graph is interesting because what it's showing is what we in the UK in 2016 spend through the life course. And I really like a life course approach to doing things. You know, we have something called the National Institute for Health and Clinical Excellence, Care Excellence now it's called, and we have, you know, there are always these things on the news about new cancer drugs come out and it's too expensive and we can't fund it. You probably have similar sort of discussions here. But actually, if you look at what we spend through the life course, look at this. On the left, you've got what we spend on young children through the school, and then whoomph, up towards that total spend, so that's social care and health care. And the middle hump in the middle is tax revenue. So we're making a contribution through our middle years to the public purse, but actually we're spending tons at the end of life. This is a picture that we put into a report that I wrote with colleagues at Bangor. And it's kind of this idea of, can we tip the spending back towards the beginning of life and prevent some of that humongous spending at the end of life? But look at this. I want you to remember this is a very linear process, okay, from birth to death. And actually, my thinking's now starting to go a bit beyond that. I'm not talking about reincarnation. Who knows who Doctor Who is here? We've got a woman Doctor Who now. Did you know that? Very cool. She's just reincarnated. So, yeah. Anyway, we're going to move on now to what. Who knows here the difference between positive and normative economics? So, I'm hearing silence. Positive economics is about empirical data. Okay, it's about producing evidence on the ICERs, cost effectiveness, your confidence intervals around those, your bootstrapping. It's about producing evidence for decision making. And I started out doing some interesting, well, I think it's interesting because it was about child parenting programs, group interventions, which can help with parenting for children who are at risk of conduct disorder, okay? And then it goes right through their life. They cost 10 times more than children who don't have this problem. And we worked out here the usual cost per point change on a questionnaire, an IBERG inventory, which is a child behaviour inventory. It's useless. How does that help a policy person? If we tell them it costs, you know, £70 or £100 per point change. So this got me thinking, how do we try and think about information that can help people make decisions? So we did some more work later on for Birmingham. They tested 3 different child behaviour programmes in Birmingham. It's great. They were focusing on prevention. Only 2 of them actually worked, and this was the Incredible Years programme again. It was developed by Carolyn Webster Stratton in Seattle. I met her, which was lovely. And here, I kind of got interested in the idea of shifting the curve. So this is my public health stuff coming out, that I quite like distributions. And can we shift the curve for the population studied for a defined amount of money? Can we talk about how many kids go from behaving very badly or to behaving better, or for having in another study we did a housing study, and we looked at preventing asthma. So we shifted the number of children. So it's this idea of, when you're thinking about presenting your data, you know, the cost of a 1 point change, you know, it's published in the British Medical Journal, but it doesn't really help. So let's think about ways where we can produce data that can help people and policymakers and commissioners make more sense. So you do things in French and English in Canada. We do things in Welsh and English. Okay. So and Non and I can talk about you all quietly without you knowing what we're saying, because we will be speaking Welsh. It's nice having another language, and it's good for the kids to grow up bilingually. So government documents, university documents, all need to be in Welsh and English. And this was a report, and this was sort of a more normative policy document we produced last year, thinking about the relative return on investment. So policymakers in the UK, they've had cost per QALY for years. It's worked quite well for drugs. So if the cost of the drug comes out at under £20,000 per quality adjusted life year, it's okay. The National Health Service will buy it from the pharma industry. It's really important to have that agency NICE. Do you have a similar thing in Canada, a break on the pharma industry? Do you have something that reviews evidence? Yeah? Yeah? So same idea. And then interestingly, if it's an end-of-life drug, it's up to £50,000 per QALY. And if it's a rare disease or orphan drug, that can be up to £90,000 per QALY. That's interesting because it's saying implicitly we're valuing end-of-life and rare things more than the boring, ordinary things other people have wrong with them. I'm not sure everyone on the street would agree with that, but that's what these decision thresholds are meaning.
You know?
Yeah?
So that number you said it's written somewhere, like you can actually find a document that states the number.
Do you want a source for that?
No, I'm asking, it is explicitly, like there's a public document that says this is a threshold.
Yeah, yeah.
That's what I'm asking.
No, but if you look at the decisions, that's what.
Oh, the decisions. Okay. No.
Panel decisions. Okay. So, I wanted to say to you that over the last few years, my interests are going upstream because I'm very conscious that health economists are very siloed. You know, if we work in hospital economics, we think about the perspective of the payer, and we think about the patient, but we don't think about everything else around. And even in public health economics, it's becoming necessary not to be quite so siloed because where do most public health prevention initiatives take place? Schools, or workplaces, or public campaigns, or government decisions about taxing sugar drinks, or stopping people smoke in public. We can't have that siloed effect. And this has just got me thinking a little bit recently. So this is Henderson Island off Tasmania. And I got really excited recently because I bought a soda stream, which would make tap water fizzy. And it was such a fantastic machine. It has 3 levels of fizziness. Well, I'm not sure if you really need 3 levels of fizziness, but it's exciting. That stops me. Actually, it's my daughter who said, have you seen online where all these plastic bottles end up in the sea? And you just start thinking, public health advice to drink more water has an impact. And we never account for any of that within our economic evaluation. I'm not saying we should, but we don't. I never even thought about that stuff.
That's a big question.
Yeah. So the big question is about, I think, is who's the payer? Who's paying? To whom are the relative costs and benefits really important for them to know? And who are the stakeholders? Because otherwise, it becomes very difficult to think about and quantify the decisions we're making.
Evaluating public health interventions.
So, the last 5 years, we've seen some papers in the UK coming out saying, what are the additional challenges? I'm not saying that pharmacoeconomics is easy. It's really technical. There's interesting work on genetics coming through now. But it's usually in a fairly controlled environment, as long as people comply and take their tablets. When you're out there evaluating exercise programs, school dietary programs, ways of affecting where you put the chocolate in the shop, whether that has an impact on decisions, you know, the nudge stuff, it gets really messy. And the things we have to think about are attribution. So if smoking levels drop in the population, is that attributable to better education among young people? Is it attributable to smoking bans in public places, or is it attributable to some kind of public broadcast on the TV or radio? It's really hard to, when you know, and if you're bringing in modelling techniques, Marx modelling techniques, or something like that to model a public health you've got to think about feedback loops, and you've got to think about attribution. There are spillover effects, positive and negative externalities. Okay, if you help a young mum learn about cooking better, the whole family might benefit. If you tell children in school that they shouldn't smoke, they might go home and nag the parents. So there are spillover effects, positive and negative. And then something that we don't really think about in economic evaluation, because we talk about means for the population, a mean cost effectiveness of QALY, for example, or a healthy year equivalent, or whatever you want to do. And that's based on utilitarian Bentham economics, the concept of welfare and utility. It's not about distributive justice, but for public health folks, reducing the inequalities in health and increasing the health of the worst off are really, really very important. So equity considerations come into public health economics.
Exercise on prescription is cost effective.
So we did a study of exercise on prescription in Wales. It was a whole study across the whole country, and you can read the paper if you want. It came out with a cost per QALY which was way below the NICE threshold. And there's a paper by Leslie Owen and colleagues from NICE which shows a lot of, according to the NICE guidance in the UK for public health interventions, about 85% of those interventions come out way below the £20,000. But we spend in the UK 4% of the NHS budget on prevention. 4%. It all goes on hospitals, drugs, staffing, litigation. No, but you know, it does. And we're spending very little on prevention, and that's in the NHS context. But I think there are some who say, well, you know, the trials need to be so big in public health to have a power, then, you know, it becomes really difficult. But actually, it's possible to do pragmatic, randomized or cluster randomized trials in outdoor education, in all sorts of things, and produce evidence of a similar quality to the evidence that's from medicine and hospital care. And so it's kind of got me thinking about this idea of, well, we evaluated this exercise program, which took part in mainly in gyms, but some of it was outdoors. And I thought, oh my God, we're starting to evaluate things taking place in the outdoors. Help. I don't know how to do that. That becomes tricky. Because in a hospital, we know about overheads, and we can attribute direct and indirect costs of interventions. But goodness me, what do we do with a park?
Market failure and public good.
So market failure happens, and for goods that it becomes tricky. So you know, for your iPod, your iPad, iPhone, whatever. I like Apple technology, because for me, with a visual impairment, it all comes with a speech. So I don't mind doing the odd advert for Apple, but other forms of technology are available. So we actually are used to markets. You know, we know about markets for things we understand, but there are things like public goods which are collectively consumed, non-rivalrous, non-excludable. So my example of that is something like a public footpath. Okay, you can't really have a market for use of a public footpath, and it's interesting that in Wales we have a footpath that goes all the way around Wales, and it generates a bigger return on investment than anything else in the whole economy, because people come, as tourists come and stay, they look at all the castles and they walk the path, and it generates a multiplier effect that has a huge return on investment of about £85 for every pound put into looking after the path. And so I think we need to just start thinking about, well, how do we do economic evaluations which involve public goods?
Appropriate evaluation of public spaces and natural spaces.
Yeah. So it becomes a case of, if you like, thinking about government and Westminster, and thinking this outdoor if you like, the architecture and outdoor environment group were really worried because local authorities were putting down the value of a park with a nominal sum of £1 because they view it as a risk, not an asset. They can't really just sell it and send it to something else. But it's not right to think of an environment that can generate health benefit having no value. It's like assigning a hospital with the value of £1 or $1. See this on playing field. So this guy, anybody follow rugby? International rugby. This is Lee Halfpenny, and my husband loves rugby. And Lee Halfpenny is a really famous rugby player for Wales, and his school, they're selling the playing field. That's crazy. I mean, it's crazy in the history of producing a great rugby player, but we have kids who are, you know, at risk of being obese and inactive, and we're selling off our assets in the UK. I was really happy. Last night, our host, friends of ours from Seattle, who live back here, we had a very healthy dinner, some salmon and some nice quinoa and things, and then they said, come on, let's go to Dairy Queen, okay? So we went to Dairy Queen, and there were all these kids coming in from baseball. That was really nice to see, because at least they played baseball before they had a great big ice cream. At home, they just have ice cream. So I think it's important for us in the UK, but I think there are transferable lessons to think about the green assets that we have and how do we build them into economics when we're thinking about these evaluations. Yeah. So there's going to be a real need for this evidence. But I'm not just standing here talking because it sounds like, you know, I think maybe thinking about plastic bottles is a good thing, or I don't like the fact that school playing fields are being sold off. The UK government are getting a bit worried about that. And what have they said? They will quantify the evidence. Okay? So that means to me that the health economists have got something to do here. And maybe we need to start talking to the environmental economists too. And I did this. I went down to London and I met up with some health economists from PricewaterhouseCoopers. They have a fantastic office right by Tower Bridge in London. It's fabulous. And then also I met at FTech, which is a company of environmental economists, and I listened to them. We had what we called a skills swap, which was great. So we talked to them about health economics, qualities, and I'm going to talk a bit more about capabilities later. Anyone heard about capabilities as an alternative to qualities? Yeah? So we'll talk about that later. It comes from Fenn's work. So they told me about how they evaluate environmental benefits, so that mainly in a cost-benefit approach, cost-benefit analysis approach, everything valued in a monetary terms. And they talk about fish and sewage and fun things like that. And actually what they said was they worked really, really hard to produce cost-benefit ratios. And it was just before the 2012 Olympics in London, and there was like £8 million Thames refurbishment to stop all this sewage going to the smelly river Thames. It's actually quite clean now. And in the end, the government just passed it because they went, oh my God, the Olympics, we can't have a smelly river. Just do it, just do it. But actually, this is the way, when economic evidence, we produce economic evidence, we're not responsible for the decisions. The decisions can hopefully be informed by the evidence that economists produce, but in the end of the day, other factors come into play. Yeah, sorry. So here, I talked a little bit earlier about linear processes. And you information people might think about this. So I think we do live in a world of linear processes, kind of produce, use, dispose, okay? And that's our plastic bottle example. But how does that translate into healthcare? I was trying to think about that. And I was thinking, well, actually, it still probably is quite linear, as opposed to a more circular model of how things interact. Okay, we do see discussions about carbon footprints in healthcare systems, but I haven't heard a lot more beyond that. So another round picture. So this is cool because Wales has an act, the Wellbeing of Future Generations Act. Does Canada have anything like that? An act that talks about the fact we have to consider future generations in every policy. You had anything like that?
I don't think so.
No, because this is way ahead of England. We always have a bit of competition, but we're way ahead of England here with this policy. I mean, it makes life a bit more difficult for everybody, but it legitimizes this concept. I mean, this is all well and good that we're at a time of Brexit now. We're facing Brexit when actually Wales is the net recipient of millions and millions of pounds of European money through agriculture, through developing poorer areas. And then we have these great goals of, you know, sustainability and all the rest of it. And actually, we may find ourselves really fairly broke fairly soon. But the point is that it legitimizes the need to think differently. Yeah. I never thought of anything like this before. Gosh, we're in a huge hospital here. How much waste does it produce? I found very little on the internet about this. But we don't think of any of this stuff in our economic analysis. And I guess that's okay because we've grown up developing economic evaluations of a specific intervention in a specific place and time from the perspective of the payer. But actually, if you think slightly more circularly about it, all that plastic waste and all the rest of it, we're getting a very partial analysis there.
Making the best of our value-based framework.
So I think that what we're going to need to do is to think, if we as health economists get asked to help with this sort of work, because I think it's going to come around as there's more interest in sustainability and this more circular idea of the economy, how is our toolbox going to be useful? So I think it's going to be useful in several ways. Do you all know that all forms of economic analysis came from cost-benefit analysis? So in the 60s and 70s in the States, cost-benefit analysis was used by the American government and RAND to organize how in the military to spend money, where to spend money, okay? And then that got used in different contexts in government across in the States and in the UK. And then, so for example, in the UK, the first example was our main road is called the M1 that runs north-south in the UK. And they had to tear down some ancient forests and they had to displace people's houses to build this road. And they conducted a cost-benefit analysis to say, well, you know, on average, for society, it's better to build this road than not build this road. Okay, net present value, positive net present value of doing that. And so, but the problem was with that cost-benefit approach was it required us to put a monetary value on health benefits. So as well as having to put a monetary value on an oak forest, you know, that's hard enough, isn't it? But to put, and that's where something called option value is interesting. So you might not go to that oak forest very often, but you like knowing it's down the road. So I think that our current interest in cost utility analysis, that's cost per quality, cost per healthy year, life year gained, may become less useful. Though I would point to one thing, which someone pointed out to me recently, which is that cost utility analysis is a very narrow form of cost benefit analysis. So if in the UK we value a quality adjusted life year produced to society, anyone in society, we're not saying who, at £20,000, that can just slot into your cost benefit analysis as the value of an outcome. I never realised that before, so that helped me a bit in linking things together. So I suspect we're going to have to become less siloed and more broad in terms of cost-benefit analysis, use of cost-benefit analysis, which does require valuing things in a monetary format, willingness to pay, shadow pricing. If you do a lit review, if you go into Google Scholar and look for cost-benefit studies in health, there aren't that many, and they were done before 2001. And then everyone started doing cost utility studies, cost effectiveness studies. There aren't that many cost benefit studies. I found some interesting ones in Norway of cycle paths, and that was done by transport economists. So I think transport economists, health economists, and environmental economists have got lots of skills to swap. I'm going to come to just one other thing in terms of our skill set. It's about allocating money to different projects. So in the UK, we still do quite a lot of programme budgeting and marginal analysis, which allows you to say what's spent currently across the programme, and if you move £5 million around, how can you get more benefit than you were currently on an evidence-based system. And then multi-criteria decision analysis is another way where you don't have one single maximand, but you want to, you might want to, you're talking about a park and you want to preserve the wildlife, you want to also increase tourism for the economy, and you want to improve health. So you've got several different goals, okay? So I think we have got a really great toolbox, and it's funny because the language about this sort of thing is used by the World Health Organization with these kind of big goals, and then there's this gap, and there isn't a lot of evidence out there, or if it's done, maybe it's done by environmental economists who say, oh, by the way, some health gains are going to come along. So I'm nearly finished now, and then I hope we can have a bit of a discussion, and I'll try and answer your questions. So I found a report from the University of Essex. There's no numbers in it, okay? So I was like, no numbers, no actual quantification. But the idea being that there are public health interventions that are nature-based. They can take place in nature. Walking groups, exercise on prescription. And then there's what is referred to as green care. I haven't heard that term before, but it's the idea of defined people, so particularly people with perhaps mental health conditions, who can really benefit from being outside. How do we measure all that? How do we measure all that in a way that is as robust as measuring the benefits of a new statin? And I think the answer is you have a go at it and just do it. And I'm really excited because I think I'm going to have the opportunity to, on a small scale, do some work developing a framework which is standardized to try and help these guys evaluate the costs and benefits of interventions. But that requires some sort of standardization of what the intervention is. It requires some concepts of dose. It requires some information about resource use. Does time in the garden mean you don't go down to your doctor for antidepressants quite so much? I don't know, but you know, it's about thinking across. So I'm going to leave you with just a few questions here. So Nani, you can read this out for me.
Can you help me with thinking about in the economic evaluation of nature-based health promotion activities and green care-based interventions for people with defined conditions? And then bullet point, perspective of analysis, societal, public sector, multi-agency, attribution of effect, spillover effect, inclusion of overhead, relevant time horizon, and should we be talking about H-qual or qual?
That's health-related quality, thank you. Health-related quality life or quality of life. So I'm going to leave that slide up and see if anybody here, and please obviously I don't see so well, maybe you can just shout out your questions. Okay, so thank you very much. I'll pick on the students if there aren't any questions.
Questions? Okay, Alex.
I suppose with the perspective of analysis, one of the problems that I have faced, kind of looking into taking a societal approach with healthcare, is who's paying for what.
Yep.
So, for example, under the NICE framework, things are quite simple if you just take the quality approach,
yep,
and you put your £20,000 per quality threshold, which represents the opportunity cost of NHS funds, and that's fine. And then when you start having benefits that, say, fall on the education budget or on crime, then it gets quite tricky, because then you've got, oh, we've got these benefits, of this health intervention, which fall in the education budget, but the health service is paying for them? Is there an argument that actually the education budget should pay for the health intervention? So I suppose from the perspective of analysis, that's always, for me, quite tricky as to who's paying for what, and if there are benefits that fall on other public sectors, should they contribute to the intervention itself, even if it's outside of their remit?
Absolutely, and we don't hear much about transfer of resources. We there are arguments about who should pay for gritting the roads at home. We don't get much snow, but one flake in the UK grinds to a halt. And the grit, which the councils, our local government, might pay for, might save people breaking their hips. And then, so it's exactly that problem. We're not very. That's why I refer to the idea of silos, both in government but also in the evaluation. It becomes really difficult. But there should be mechanisms for transferring resources from one sector. It's a kind of compensation idea in economic theory, isn't it? That it should be possible to compensate winners and losers at government level, really.
Question in general, how wide do you take the scope? Just take back your example of people being told to drink water and everyone's carrying on plastic bottles. If you introduce some policy to limit, restrict use of plastic bottles, or maybe people stop drinking sugary drinks at school and start drinking water out of the water fountain, there are knock-on effects to the economy. I'm not saying that they're not deserve it, but maybe the bottling companies go out of business and people lose their jobs. And how far do you have to go from the initial intervention? How far do you have to go to look at the consequences before you've gone far enough?
I don't know, and that's why I put these questions up. I mean, NICE likes to take a lifetime time horizon. So one of the things I didn't really talk about, but it was on the slides, is this idea of what horizon do we take. But actually what you've just said now is the argument that was made about the cigarette industry, wasn't it? And the fact that the cigarette industry, produces massive tax, which some of it goes into healthcare, and then there are jobs, and then there's export tax. So it's complicated, isn't it?
Mm-hmm.
Yeah. So I don't know, but I think I do feel there is a need to lengthen time horizons and broaden perspective and be very explicit about it. So wouldn't it be nice if I think it would be nice over the next 10 years if some papers started being published which are more like cost-benefit studies that very clearly set out, cost-consequence analysis is a method that doesn't aggregate, but it allows you to put things out clearly. And it might be necessary to do those two approaches, which are promoted by NICE for public health intervention and evaluation. It'd be nice to have a go at that, to build up a literature trying to address some of this stuff, because otherwise I think you see these broad studies done in developing countries, and you see them probably done by environmental economists who are looking at a new project like building a dam, or as I said about Thames, reducing waste in a river, and then they'll just tag in some health effects. But I don't think they're using the toolbox we've got to hand to do that.
So I'm wondering whether this is an idea that came up when you were saying this particular slide, right? In the environmental sector, they use a cap and trade system. A cap and trade cap and trade system solution, for example. Yeah. Right? So that concept, if you apply to this scenario, you will see whether municipalities and federal and provincial governments start to do something similar, but this time they are being penalized if they don't have enough green spaces. It's just
that's really interesting. Can you say a little bit more about that?
Well, it's just something that I know in the environmental sector they are using that to control pollution.
Cap and trade. So you cap the emissions, but you also allow people to trade. Right.
So the same concept. Of course, I don't know how to apply it exactly, but I'm just thinking whether it's conceptually wise.
Well, I think that would be good to be able to look across at what other people and transport people, what they're doing. I think that would be really cool. Good idea. Thank you very much. I'll take that away and read about it.
Thank you so much. This is really interesting. And so I did some work with the Wellesley Institute on green space and mental health, and it fits really into this issue where we tried to, so we did a scoping review. We also tried to develop a theoretical framework, and part of the issue was just the time horizon. Like how long does it take to see effects from green spaces, and particularly because planning initiatives and construction takes so long, and sometimes you see issues in the interim, right? Construction or pollution or accessibility issues. And so there are all these sort of complex things come in, but yeah, I'd love to chat more about that.
That would be really good, and I'll put my, if you can email me about that, that would be really cool. All right? Okay, any other questions? We have plenty of time. And if anybody does want to email me about anything in particular, I'd be really pleased.
Okay, no, I can, I guess I have two questions. One, I would like to hear a bit more of your experience meeting or kind of the knowledge swap with, say, environmental economists or other specialties. And my other question goes back to what was said already around scope. Like, I find that really interesting. How far do you go? And in terms of scope, also, are we looking at, at the problem from a national perspective? So it's kind of like who pays for it? Or are we looking at it from potentially an international perspective, right? So I'm working a lot in infectious diseases. So companies say, we require, in terms of immigration, we have certain rules around TB. If people have TB, they have to get treated in their home country before they can come in. So do we care about those costs? No, we usually don't. But should we care about it? Do we care about, I guess if they don't do it, like what's the prevalence of a disease in another country that may be coming back to us? And I think that could be transferred to a kind of other problem. Kind of, the plastic waste, or, it doesn't necessarily end up in our own country and maybe ending up somewhere else. So it's a scope question and also the kind of knowledge.
Well, I think I can answer that in terms of, I've done quite a lot of work with Welsh government and then also with the English government through public health organisations. And often they don't know really, they want our help to help frame questions as well. So one of the worst things I ever did was to do a programme budgeting exercise on prevention, and nobody told me what the goal was. What was the government goal? They didn't know. They didn't have a goal. It's impossible to review evidence on a load of different options if you don't really know, was the goal to promote child health or prevent ill health later in life, or get rid of useless treatments that don't do anything. So I think if you were in the position of being a health economist working with a team and helping government, I think we have to really just make them decide what do they want, because then that helps define, as you said, the scope, and it helps define what the research question is or the policy question is, which then you can do an evidence review, but then also maybe you can do evaluate a new programme. And I suppose the job of the health economist, Tony Collier said that the job of the health economist is to be a dispassionate analyst. Okay, so that means somebody we really are unbiased, and we don't know what the answer is going to be. But actually, that's not quite true, because he also wrote a paper back in 1989 about the normative economics of healthcare financing, and you should read it if you haven't read it. It's a great paper. And the normative side of things is that actually most of us really want to see society produce more health. So we're trying to be objective, but we underline and have a goal that more health is better than less health. It's kind of like economists thinking more welfare is better than less welfare. So I think it's always about being explicit, defining what the policy question is or the research question is. And I put it on 2 slides. Who's paying? Who's paying? But the problem, as we said, we send all our plastic bottles end up near Tasmania on Henderson Island, apparently, and that's, if you like, that's an externality we're not paying for. But maybe there should be a trade, and that's what this excellent suggestion was. You can trade carbon, maybe you can trade bottles as well.
I have one question online here. That comes from Petros.
Hi, Petros.
Such broad perspectives imply that policymakers and ministers can make decisions that they know that have consequences or savings that fall outside of the responsibility.
Yeah.
Would you have examples where such broad perspectives worked in practice in policymaking and public health? And is it feasible to expect that such inclusive decision-making process can be conducted for every or many decisions?
You need to tell Petros that he's just had a little girl, apparently that's why it's not his day. She must be sleeping really well if he can produce a question like that. She's beautifully. I don't remember my kids sleeping quite that well. Come on. So to answer that question, I think in the UK, the government treasury produces guidelines. It's called the Green Book, and that's about evaluating interventions like building a new railway, like a train line or whatever, across government. And I think intrinsically we're having to look towards that level. So instead of just National Health Service, nice economic evaluation, going towards the Green Book and thinking what would the Treasury approach to evaluating costs and benefits mean in a healthcare setting, and also that public health people want to make health the business of every department, because I think what Petros is saying there is, why should transport people get excited about the fact they're improving people's health by reducing emissions? They don't get rewarded for that. That's the problem. So we're coming back to this trade. I mean, I don't know about the cap bit, but the trade bit I kind of understand. Or for example, a water industry, they pay farmers to plant legumes, so radishes and things, to take nitrates out of the water before the water goes into the river. Then they get paid for that, and that you're getting trade between sectors. So those are two examples. But it is a problem, because at the moment if better housing improves health, respiratory health, which we know it does, I've heard local authorities in the UK complain that really the National Health Service should be paying for housing. We do have systems that are interesting, something called boiler on prescription. That's the idea that you've got an old lady in hospital, she can't go home because the house is cold. So the hospital hires a plumber to go and fix her boiler, and that's a boiler on prescription. So we are trying. There you are, Petros, 3 examples. So I've tried. We are trying, but they're all demonstration projects at the moment.
Okay, good, thanks.
Do you think, for me, like one of the big problems, if you're taking the broad perspective, is valuing health in monetary terms?
Yeah.
Because for me, like the understanding is the nice threshold represents the opportunity cost of NHS funds. So if you were to ask someone what their willingness to pay for a QALY was, then that may exceed the opportunity cost of the fund. So say society's willingness to pay for a QALY was £100,000, then we might say, oh, this is a great intervention, and then we do it, but then we end up producing less QALYs for society because of the displaced funds. So I find trying to monetize health quite difficult, especially because it kind of conflicts with one of our other key objectives, which is the equity consideration. I know there was an interesting Free Economics podcast which was talking about why don't we just say, like, the average cost of a life from birth to death, say it's £100,000. Why don't we just give people £100,000 and say to them, if you need any healthcare, you have to pay for it out of that £100,000.
So you can put that in an insurance.
So you can put that in insurance and do what you want with it. But the problem they found with it was that, of course, everyone who said yes to that tends to be from a lower socioeconomic background, and they tend to be the more sick. So they were exceeding that cost anyway.
You don't
and all
the risk then.
Yeah, and all the rich were saying no. So it was the kind of, when you start bringing money into health, you kind of introduce these equity concerns and these inequalities where wealth can drive policy.
Well, I follow that to some extent, except first of all, the National Health Service in the UK, and I'm sure your systems here in Canada as well, are a net, huge net transfer of welfare to poorer people. So we've got some systems going on in the economy already. To answer your question, the law courts pay out on injury, illness, death. So we do in society place a monetary value on health. I think also the idea of that £20,000 figure, or I think it's about 50,000 here dollars. The idea of that sort of equates to average household income, disposable income in the UK. So benchmarking it against something, you need some logic to resources, and then I think it's sensible to take that threshold right across society. We don't do it for willingness to pay for improving education for children. It's quite unusual that that's happened in healthcare as opposed to other areas. But then we have the opposite, where we have austerity happening with no evidence. If we go back to that Michael Marmot slide at the beginning, where this guy's saying, hang on a minute, life expectancy increases are slowing down. And we're spending less on education, less on social care, and we haven't had this debate about how much to spend or what we value. So you could criticise health economists for putting monetary values on an extra health a year, but at one level that's an amoral, not immoral, amoral thing, because you're not saying who's getting it. But I'd like to continue this conversation, Alex, another time. Cool. Are we nearly up at that time?
I think, yes, we may have a time for one question.
One more.
That's it, if anyone can. Oh, no. Nothing online? No. Okay. No more questions. Then, yes, then. Thank you for coming, and thank you for presenting.
Thank you. Thank you for your time. And, it's the holiday time. Well done for turning up. I hope you go away with our newsletter from our centre. We're always glad to have visitors. So, if you find a way of coming and studying or visiting, or you're on holiday in the UK, come and visit and enjoy your summer.
Thank you.